Good morning, everyone. Welcome to May 8th Clinical Conference. I am very pleased to announce our speaker today, who is now a member of the Madison Clinic as well, Dr. Chris Longenecker, who is our new HIV cardiologist at Madison Clinic. And he's going to be talking about an integrative approach to cardiovascular disease prevention in people living with HIV. He is an associate professor in the Division of Cardiology in the Department of Medicine, as well as in the Department of Global Health here at University of Washington. He is the inaugural director of Global Cardiovascular Health Program, which was much needed here at the University of Washington. And he attends on cardiology and the Madison Clinic. We're not only doing managing cardiovascular disease, but also prevention in our patients. He has a long research history, primarily conducting research in the US, but also in Uganda on cardiovascular disease in people with HIV. And he is funded by the NIH, American Heart Association, and we are very pleased to have him speak about how we can better manage our patients in prevention of cardiovascular disease. So thanks, Chris.
Thank you, Shirisha, for that introduction. It really is a lot of fun to do these sorts of events, and I'm very honored to be invited to speak with you all today. I will, as I mentioned, make sure that I stop at least at the latest 10 till to make sure that we have plenty of time for discussion. So a few slides of disclaimers as per the usual. These are my disclosures. I will not be specifically talking about drugs from Misfortune Pharmaceuticals in great depth, but just so that you know, bempedoic acid is a new cholesterol medicine made by that company. This is the outline. We're going to begin with a brief epidemiology of cardiovascular risk in people living with HIV, and then proceed in two parts to discuss both mechanisms of CVD risk in people living with HIV, as well as what I'll call an integrated approach to cardiovascular disease prevention, and very, very case-based and hopefully very practical for the clinicians on the call. And then we'll end with some conclusions. So right off the bat, I think many in the audience recognize this or have known this for a while, that people living with HIV have a higher risk of coronary artery disease. And this slide, adapted from Steve Grinspoon, shows that over the last couple decades, there have been a number of epidemiologic studies that have shown about a 1.5 to 2-fold higher risk of myocardial infarction, coronary heart disease, defined slightly differently in some of these studies, but in essentially 1.5 to 2-fold risk. Now, most of these studies have been done in high-income countries, and clearly a lot of my work is in East Africa. We are not sure if that same risk applies to people all over the world, but we think this is probably true. The other thing is that it's not just coronary artery disease. There are a broad range of cardiovascular disease for which people living with HIV are at increased risk. As shown in this publication from the VA cohort study, the risk of heart failure is about 50% higher in people living with HIV. And there's a higher risk of both HFpEF, preserved ejection fraction, and reduced ejection fraction. You can see there are certain subgroups in which the risk is even greater, particularly for those who are younger, that HIV-specific risk is greater. And in this meta-analysis published last year, you can see that the pooled risk seems to be about, again, similar to coronary heart disease, about 50% to a 2-fold higher risk. So something that we have to keep in mind, this holds true for other things like atrial fibrillation as well, but we won't be going into that in great detail. I would like to highlight, however, that this risk seems to be higher in women, particularly, and this is an analysis that really kind of launched this field back in 2007 from the partners health system in Boston, Virginia Triant, showed that the risk for women, the HIV hazard ratio is higher for women than for men. And so we've seen this in other ways that cardiovascular disease is different in women with HIV compared to men with HIV. In this analysis from CNIX by Heidi Crane. I don't know if Heidi, yes, Heidi is on the call. Women with HIV have more type 2 MIs than men with HIV. So then coming back to this meta-analysis again, if you look at the relative risk in women, it's significantly higher than men, so 3.5-fold or 3.6 relative risk in this case. So something that we've thought a lot about now, of course, when we think about mechanisms of risk in women with HIV, we've known that women with HIV have more inflammation, immune activation response to the virus, and this may be adaptive and help them to achieve lower viral set points, but may be maladaptive in the long run for non-communicable diseases like cardiovascular disease. But there are other sorts of traditional risk factors and certainly treatment disparities that are relevant in terms of hypertension, dyslipidemia, dysglycemia, and behavioral and psychosocial factors that may, in certain populations of women living with HIV, play a role. But there's also this concept of reproductive aging, and I've been interested in this as well, and how that might be promoting cardiovascular disease in women with HIV. So if you're interested in learning more, this is a nice review from Markella Zany and colleagues, and there are other reviews out there as well. So let's talk a little bit about mechanisms of cardiovascular disease in people living with HIV. I like to portray this as three bubbles, and the first being traditional risk factors. We know that when we think about traditional risk factors, that there may be some residual confounding in these epidemiologic studies that we're not able to control entirely for the fact that people living with HIV do smoke more or have hypertension or cholesterol that we're not accounting for. But when you think about antiretroviral therapy, things have changed a lot over the last couple decades, and our current regimens certainly contribute a lot less to cardiovascular disease risk in 2022 than they did back in 2002 or 2012. And now we appreciate that inflammation and immune activation are perhaps playing more significant roles in certainly when we think about that residual risk that's due to HIV infection. So we'll spend a few minutes talking about this. I do believe strongly that as most in the audience I'm sure would agree, that the benefits of antiretroviral therapy outweigh the risks of not treating someone with HIV. This is true for cardiovascular disease as well. So clearly HIV and chronic inflammation are a more important risk factor than specific ART or ART in general. What do we know about this from clinical trials of antiretroviral therapy? You all remember the START trial, and what was noted interestingly is that, you know, if ART is helpful to reduce cardiovascular events, we would expect to see that perhaps in these trials, but did not see that in START. There was no signal for a decrease in cardiovascular events with early ART versus delayed ART. And even when you looked at a surrogate measure of small artery elasticity, there really was no difference between the groups. So the question is, why is this? And Peter Hunt has thought about this and presented this previously. And his idea is that perhaps this is that cardiovascular disease and other non-communicable diseases may be complications of low nadir CD4 count. They may be quote unquote low CD4 nadir diseases. Because if you look at SMART, which had people with much lower nadir CD4 counts, their event rates were significantly higher than in START. So something that I see a lot of, and many of you know, that people with very advanced AIDS who have low nadir CD4s may have persistent issues with chronic inflammation. So the question is, can we target inflammation in people living with HIV? And this is just one example among many approaches being taken. Priscilla Hsu has this study at UCSF looking at 110 people living with HIV. They were having some troubles with enrollment, but expect to have the study completed by December 2022. And looking primarily at safety of this IL-1 beta antagonist, which was canakinumab, which was used in the CANTOS trial. But there is an efficacy outcome as well, looking at FMD, flow-mediated dilation of the brachial artery, and aortic FTG uptake by PET-CT. So as you may remember, CANTOS was a trial of 3 different doses of canakinumab. And in that study, the canakinumab was associated with a reduced risk of a combined primary cardiac endpoint of about 15% relative risk reduction. And so this was heralded as proof of the hypothesis that inflammation does lead to cardiovascular disease, and that by targeting it, you may be able to reduce cardiovascular events. But whether this is actually the risk is worth the benefit in people living with HIV, we really don't know. In Priscilla's study, they have published the first 10 patients looking here at PET-CT and found that there was a decrease in aortic FTG uptake by about 10% after a single dose of canakinumab. So the jury's out, but kind of an interesting proof of concept. We also know that inflammation leads to cardiac fibrosis, so fibrosis of the heart muscle itself, and this may then lead to other problems such as heart failure with preserved ejection fraction, as well as more reduced ejection fraction cardiomyopathy. But it also leads to sudden cardiac death. And in this paper published in the New England Journal last year, they showed that people living with HIV who have sudden cardiac death had a lot more fibrosis than people without HIV who had sudden cardiac death. So again, can we target inflammation to decrease cardiac fibrosis and improve not only coronary heart disease, atherosclerotic cardiovascular disease, but also heart failure and sudden cardiac death? So that's a little bit on inflammation, but when you think about it, traditional risk factors are actually still probably the most targetable and most important contributors of risk in this population. So when we think about risk in our population on a population level, we have to think not only about the relative risk associated with that risk factor, whether it's inflammation or a traditional risk factor, but also the prevalence of that risk factor in the population, right? That leads to population impact. And when we think about the population impact of traditional risk factors, I think this analysis from the North American AIDS cohort collaboration really does highlight the importance of traditional risk factors. So the top 3 risk factors in terms of population attributable fraction for myocardial infarction, it's impressively higher than for other HIV-specific risk factors such as low CD4 count or high viral load. This is a little bit different than other non-communicable disease comorbidities such as liver disease or kidney disease, for which these HIV-specific factors actually play a more important role. So for cardiovascular disease, specifically myocardial infarction, makes sense to focus on a population level on total cholesterol, hypertension, and smoking. The problem is that we know that despite this, guideline-directed medical therapy is prescribed less often for people living with HIV. This is particularly true for statins, but also potentially other preventive measures as well. Aspirin issue is a little bit beyond the scope of today's discussion. Happy to come back another time and talk about aspirin, but certainly for statins and cholesterol, guideline-directed medical therapy is prescribed less frequently. And so when we produced this scientific statement for the American Heart Association a couple years ago, we really wanted to highlight the fact that there are many opportunities to improve cardiovascular disease prevention care that leverage the HIV infrastructure that we do have to deliver better and more optimal cardiovascular disease care and prevention for people living with HIV. And some of the examples that we threw out in this statement include strengthening specialist referral pathways, nurse management, co-located clinics like we have at Madison, and that sort of thing. So that leads me now to the second part, which is going to be the more in-depth part of this presentation, which is implementing cardiovascular disease prevention in HIV clinic care. So I'd like to begin with an exercise, and I have gone through this exercise with the ECHO group a couple weeks ago, and some of you may have heard this in other forums as well, so apologies if you've already heard this, but I find it's a useful way to think about the opportunities that we have in HIV clinics to really make a big difference for our patients. So let's pretend that we have two patients on our panel here. The guy on the left we'll call Greg, and the guy on the right we'll call Bill. Now, Greg here is 50 years old. He's had AIDS in 2002, has had HIV for a long time, has been on ART ever since that time, with a nadir CD4 count that was quite low, 20, but currently 600. And compare him to Bill over here, who's also 50, but who was diagnosed with HIV through routine screening and also has been on ART, but not quite as long, with a nadir CD4 count that was higher and a current CD4 count of 1,000. So of course, did you see that? They both smoke, like many of our patients, unfortunately, although that is also decreasing. And Greg over here has a blood pressure of 140/70 on amlodipine 10 and an LDL of 100 on atorvastatin 40. Whereas Bill has a normal blood pressure, not on therapy, and an LDL of 100 on atorvastatin 40 as well. So the question now is who's at higher risk? And I think many in the audience would recognize that Greg over here is at higher risk, perhaps if this is a low nadir CD4 disease. He's been on ART longer, he has treated blood pressure is higher. So again, for many reasons, perhaps he's at higher risk. But here's the kicker. This guy is Sam. He is 50 as well, but he's HIV negative. And because he doesn't have a chronic disease, he is, and also smokes, but is walking around with an untreated blood pressure of 150/90 and an LDL cholesterol of 160. And again, because he's not engaged in primary care, doesn't know he has these risk factors. So now who is at higher risk? I would say it's really this guy, Sam, in the middle, illustrating the point that if our patients living with HIV are engaged in care, we have an opportunity to do these things that can prevent cardiovascular disease, improve cardiovascular health. So I'm going to now present a first case, which I'll call high-risk coronary artery disease. And this is a 54-year-old African-American man with HIV who has a current CD4 count of 871, a nadir of 258, and a suppressed viral load on boosted darunavir FTC TAF. So he presents with 1 month of this dyspnea on exertion with a stabbing sensation in his chest. It is relieved with rest and has no relationship to dietary patterns or body position, no cough, fevers, chills, and has some risk factors. He's a cigarette smoker. His brother died of a heart attack at age 52, and he has no hypertension or diabetes. His medications are really pretty simple. All he's on is ART and multivitamin. And these are his lipids. Not so bad, actually. Total cholesterol of 167 off of a statin. And this is his baseline ECG, pretty unremarkable. So what would we do for this patient to further evaluate his chest pain? Would we do a stress test? I think many in the audience probably would proceed with a stress test, or maybe you're convincing enough to go straight to cath if you think he's going to need an intervention. What about cardiac CT? I think this has really changed the landscape, and I think might be what I would choose now if this case were coming across my schedule at Madison Clinic in 2022. But back at the time when I did see this patient, we decided to order a stress echocardiogram. So you can see here at peak exercise, he had ST elevation in AVR and diffuse ST depression in other leads, maybe even a little ST elevation here as well in V1, V2, and AVL. So this is a very high risk EKG finding. But in addition, his ejection fraction decreased from 60 at baseline to 35% with transient ischemic dilatation of the LV during the stress test. So obviously very concerning, and we did a cath. So you can see a still image here of his left anterior descending, which has a significant 95% lesion that even goes a little bit into the left main coronary artery. And so you can see that here in a movie version. And so he was someone who really did not want to proceed with bypass surgery. So he wanted to get a stent, and we do that nowadays. So he had a stent to his proximal LAD, extending back into his left main. And you can see he has wired down the circ here to protect that, and did really, really well, actually. So his angina went away totally, did not return, and as when I left Cleveland, had not returned in greater than 8 years. He stopped smoking, which I think from a cardiovascular risk standpoint was really the most important thing, not the stent. And he has had no recurrent adverse cardiac events, now on atorvastatin 80 milligrams daily. So this case illustrates that smoking and a family history can be important risk factors, even if your cholesterol is not that terrible. So what do we do for antiplatelet therapy? I think this is an opportunity to discuss how we prescribe antiplatelet therapy in someone who has a boosted ART regimen. As you recall, he was on darunavir and cobicistat. So remind everyone that ticagrelor is contraindicated in people who are on boosted regimens due to metabolism via the CYP3A4 pathway. And it turns out that clopidogrel and prasugrel are actually prodrugs that are also metabolized by this pathway. So if you inhibit those pathways, then you lead to decrease actually in the active metabolites, because it's required to get the active metabolites to go through those metabolic pathways. And so the AUC and the Cmax of both active metabolites for clopidogrel and prasugrel are decreased in patients on cobicistat or ritonavir. However, because prasugrel is a stronger antiplatelet, the antiplatelet effect is preserved compared to clopidogrel. And so for people who have a stent on a boosted regimen, our recommendation is typically to prescribe prasugrel. So this patient had left main proximal LAD disease, and it would have been very reasonable to do bypass surgery. Even all he would have needed is a lima to his LAD. And so the question is, what are the risks of bypass surgery in people living with HIV? This is several years old now, but from the Cleveland Clinic, looking at the nationwide inpatient sample, a little bit older time period. But even though it was older, what they found is that in this propensity matched analysis of various types of cardiovascular cardiac surgery, including CABG, people living with HIV actually did pretty well. And so you can see that for mortality, there was really no difference between people living with HIV and the people without HIV in this analysis. But there was a signal for a slightly increased risk of any complication, including decreased risk of stroke, interestingly, but increased risk of blood transfusion. Sorry, that arrow should be pointing to pneumonia here, which is slightly increased risk. So, people living with HIV can safely undergo cardiac surgery, especially those who are suppressed on ART with relatively normal CD4 counts. So the second case is a case that I'll call genetic misfortune. This is a 49-year-old African-American male who, interestingly, from an HIV standpoint, maybe has genetic fortune or had genetic fortune, and was a long-term non-progressor who was able to achieve near elite control of his HIV with viral loads usually less than 50, but occasional blips, and a CD4 count of 900. At the time that I saw him, he actually, this was several years ago now, he was not on antiretroviral therapy. So he had several months of an atypical intermittent stabbing chest pain, really not not classic for angina, worse at night, but not related to food, no other cardiac symptoms, and really was limited in his functional status by chronic low back pain. So wasn't very active. So not quite sure whether this was cardiac or not. He had some significant risk factors though. So he's a prior smoker, he had hypertension. And here you can see his LDL cholesterol was 240. And this was actually on a statin. He had no diabetes or other pertinent family history. And notably, from a social determinants standpoint, lived in East Cleveland, where he had limited access to nutritious food and safe exercise options. These were his meds, and his labs showed that he had a little bit of elevation of his AST and ALT, and his TSH was normal, CK was normal. So CKG was normal, Zeca was basically normal, his nuclear perfusion scan was normal, and he even went to the emergency department with these symptoms and got a chest CT to rule out dissection or pulmonary embolism, also negative. And on the chest CT, they noted, although it wasn't protocolized for the coronary arteries, that he had no coronary artery calcification. So pretty significant that despite that high LDL, he had not developed coronary calcium. He had, however, hepatic steatosis on that CT as well. So what did I make of his chest pain? After all of this workup, I was pretty convinced it was not cardiac. But nonetheless, what should we do with that very, very high LDL cholesterol? So he would fall into one of these primary prevention groups that are defined by the 2018 ACC and AHA cholesterol guidelines. And so he certainly has an indication to be treated, because over time, even if he doesn't have coronary calcium now, he may develop cardiovascular atherosclerosis later on and be at risk for myocardial infarction. So just to point out that the National Lipid Association did sign on to those 2018 guidelines, but interestingly, just 3 years prior to that, had published their own set of guidelines and some very specific recommendations for people living with HIV. So if you're interested, you can go back to that. And the NLA approach was to think about targets for LDL cholesterol and to try to achieve targets, which, as many of you know, was not necessarily the focus of the 2018 guidelines. So I'll just point out that for people living with HIV, they considered that a risk factor. And if you had other risk factors like hypertension or dyslipidemia, it was pretty easy to get to 3 major risk factors. And for these people, the recommendation was to try to get LDL cholesterols less than 100, or non-HDL, which is simply the total cholesterol minus the HDL, less than 130. And so what would we do? What should we do in this situation? So again, as I mentioned, you can think about cardiovascular risk in terms of 10-year risk, but you should also think about it in someone who has a probable familial hypercholesterolemia, their lifetime risk, right? And so by treating the cholesterol over decades, you're going to lower their lifetime risk. And so I titrated his atorvastatin to 80 milligrams. And thought about adding additional agents. So what would we add if we added something else? Would it be ezetimibe, perhaps a PCSK9 inhibitor, or other drugs, which there are newer drugs all the time nowadays. Some people, I think, would be concerned about his hepatic steatosis, and this is for Jihan, who may be on the call, maybe not, but we were talking about this in clinic the other day. What about statins in people who have hepatic steatosis or steatohepatitis? So this is data from the Improve It trial several years ago now that showed that ezetimibe plus a statin did lead to a modest decrease in the risk of a composite cardiovascular endpoint. And so I think the evidence is pretty strong for ezetimibe that we would recommend that as a first step. But with an LDL of 240, it may be necessary to add stronger drugs eventually. So what about PCSK9 inhibition? So this study from Priscilla Schu's group, again, initially presented at CROI many years ago now and published in JAHA, showed that people living with HIV actually tended to have higher PCSK9 levels, and that was true particularly in those with hepatitis C co-infection. In a very small subset of 6 patients who participated in the evolocumab trial, they saw a similar LDL response for those 6 patients, which was 61% reduction in LDL cholesterol on top of statin. So this little graphic over here shows how PCSK9 helps to degrade the LDL receptor. So if you have higher PCSK9 levels, you have less LDL receptors on the surface of the liver, and you're unable to clear LDL from the blood, at least as efficiently as if you had more LDL receptors. So by inhibiting PCSK9, we can put more LDL receptors on the liver cell surface and get rid of more LDL from the blood. So as you know, monoclonal antibodies were developed to do this. That's what evolocumab is, or alirocumab is the other PCSK9 inhibitor. And those are now on the market. And although they were very expensive several years ago, their price is coming down and are increasingly available for our patients. So let's talk about non-alcoholic fatty liver disease. And we know that NAFLD increases risk of cardiovascular disease through multiple mechanisms, some of which include inflammation, as shown here. And we know that HIV contributes to all of these things. So people living with HIV and fatty liver disease are particularly at increased risk for cardiovascular disease. So what about the management of cardiovascular risk in patients with non-alcoholic fatty liver disease? Lifestyle changes are clearly central to management, but we do also know that statins are safe and effective. I'll show you some data on that in the next slide. The 2014 NLA statin safety guidelines suggest that it's safe, but if you ever have questions, you can always consult with your gastroenterologist colleagues. But as shown here in this review, statins do potentially have many benefits in this patient population, not only for cardiovascular disease, but even potentially on the liver and liver disease progression. So in this trial from the IDEAL study, it included about 1,000, the trial overall comparing simvastatin and atorvastatin was 7,000 patients, but 1,000 of them had elevated liver enzymes at baseline. So those are the open triangles and squares here. And you can see for those who had elevated enzymes at baseline, they actually had a decrease in their liver enzyme over the course of the trial, whether that was simvastatin or atorvastatin. And then for those who didn't, there was really no change or minimal elevation. So the key points here is that this was a case of primary prevention in a patient with probable heterozygous familial hypercholesterolemia, but also who had steatohepatitis. And he was a 49-year-old who he was an elite controller, not on meds at the time, but I didn't really talk a lot about this, but those patients, elite controllers, have been shown to have increased risk of non-AIDS events. And so his primary HIV doc did later start antiretroviral therapy after finally convincing him to do so. His LDL treatment goal, from my standpoint, was to try to get him less than 100. So did we ever achieve that? Again, like I said at the beginning, 240 on atorvastatin 40. There, I think, was some issue maybe with compliance. So we were able to increase his atorvastatin to 80, added ezetimibe, and his LDL fell to the 160s, and his AST and ALT actually improved. And so this was great. We were on the right track. But again, 160 is not the treatment goal. So eventually we did add a PCSK9 inhibitor, and his LDL now, I'm happy to say, before I left Cleveland, had finally fallen to less than 100 milligrams per deciliter. And so again, just to say that HIV is a known cause of fatty liver disease, but most patients with elevated liver enzymes can be safely prescribed a statin. So we mentioned that for these sorts of patients who have metabolic syndrome, it's really, really, really important not just to perseverate on on meds and giving statins, although that's really important. But we have to talk about lifestyle and all of these things that are part of Life Simple 7 as well. So things like stopping smoking, losing weight, eating better, and getting active are things that sometimes we don't go into as much detail as we should in clinic. But there are barriers to this for some of our population. And it includes poverty, chronic stress, food deserts, and safety during exercise. So for this patient who lived in East Cleveland, these were some of his significant concerns and some of the issues that he had to deal with, and also substance use in some situations. And this requires a team-based approach to cardiovascular disease or cardiovascular risk reduction. And so in Cleveland, we did this, and I'm really looking forward to further developing the cardiovascular prevention efforts at Madison Clinic. But we had primary HIV care docs, dietitians, social workers, smoking cessation counselors, and nursing staff working together to try to reduce cardiovascular risk in our patients. And so we really do believe that now is the time to extend the HIV treatment cascade beyond just viral suppression, right? Because if we achieve 95, 95, 95, our patients are still at risk of dying of other things, non-AIDS comorbidities. And specifically in my case, I'm interested in ASCVD risk prevention. Primarily, again, if you go back to that analysis from NA Accord, smoking, blood pressure, cholesterol, those are the things we need to focus on. And we need to appropriately diagnose those conditions, appropriately manage and prescribe the medications needed to get people ultimately to both blood pressure and cholesterol goals. And so how do we do this? Well, there are barriers. There are unique barriers in our population. And something I hear a lot about from patients is that I always thought I would die of AIDS, and so does it matter? I didn't need to worry about cardiovascular disease prevention. And if you look at perceived risk in our patients, according to their actual ASCVD risk score, there really is no correlation. So people who are at high risk don't necessarily perceive themselves to be susceptible to risk. So how do we work on improving that perception of risk? There are other unique barriers in the HIV clinic context. So one of them, which I think is a bigger problem out east, in Cleveland and Durham, where we're conducting this clinical trial, but this issue that there are HIV docs and then there are primary care docs in co-management of patients. And so this analysis from Duke that Lance Okeke published in OFID showed that for hypertension and hyperlipidemia, you had kind of a smattering of different people prescribing blood pressure meds. So an ID doc was doing it in some cases, sometimes primary care, sometimes a specialist, and then people were on no meds in many cases here. About a third of patients for hypertension and a half of patients for hyperlipidemia were on no meds. And when they looked at this further about how patients were doing on these medications, they found that if ID was managing your blood pressure, there was about a 16% lower chance of control than if your primary care doc was managing your blood pressure. So again, not to knock on HIV docs, but in this analysis, it was just kind of interesting to see this. And so the issue, though, especially for our patients in Cleveland and in Durham, they really, really, really trust their HIV docs. And so this quote, I think, from our qualitative work in our study just really illustrates that. I just have an HIV doctor, and he asked me the last time I was in if I had a primary care doctor, and I said, "That's you." He said, "No, it's not me." And I said, "I just have HIV. Nothing else seems to be wrong with me. So you're my primary care doc until such time as I feel I should see one." So this is the kind of thing, the tension that exists. And I think much less so at Madison Clinic, but in some settings, it is important. So we also know that the funding landscape for HIV care also affects how we care for people living with HIV, and I think presents opportunities through Ryan White and other programs to perhaps try to focus a little bit on non-AIDS comorbidities such as cardiovascular disease. So this is our study called Extra CVD, a nurse-led intervention to extend the HIV treatment cascade for cardiovascular disease prevention, which is a collaboration of a number of different institutions you can see here. And it's actually part of a consortium of projects around the country that are working to try to improve heart, lung, and blood disease care, primarily cardiovascular disease care for people living with HIV. You can read more about this consortium if you're interested. So as part of our project, we conducted a formative assessment of 3 academic medical centers. This is University Hospitals in Cleveland, Metro Health in Cleveland, and Duke Health, and conducted focus groups and semi-structured interviews to ask what are the constraints on and opportunities for integrated cardiovascular disease prevention care for people living with HIV. And these are some of the key facilitators, some of which I've mentioned, but others I'll point out include the value of self-monitoring. Our people, our patients living with HIV intrinsically know their value of monitoring their viral load, right? Am I suppressed? So perhaps giving them a number, of blood pressure target. Remember, 130. Try to get under 130, or a non-HDL cholesterol target. Maybe that idea of self-monitoring is something that could be leveraged. But there are barriers. There are clearly lots of different people trying to get to patients in clinic. You have research, you have your cardiologists, HIV, social work. So all of these different people wanting to care for our patients is great, but it does create bottlenecks in clinic flow. There are other barriers as well highlighted here, including things about HIV providers maybe not messaging as intensely on cardiovascular disease risk reduction as we'd like. Another issue is this issue of differential adherence to treatment. So our patients, used to have to take a cocktail of meds, but now have 1 pill once a day. And this has really helped them to try to think, I want to try to reduce my meds as much as possible, and I don't want any more meds than I need. And so what often happens is, we saw this in our formative assessment, that patients, took their ART, but then selectively decided to take other meds such as statins or blood pressure meds. And so working with patients to try to understand those barriers is important. What about the influence of healthcare financing? So in certain healthcare systems, there's pressure for infectious disease doctors who are treating HIV to just see more patients all the time, to generate more and more RVUs. And in that setting, focusing on blood pressure and cholesterol is just not really incentivized. And so I think it is important to think about, maybe not as applicable to all settings. So using this formative assessment that we conducted, we went through a human-centered design approach to engaging a team of stakeholders to design this nurse-led intervention. I'd like to acknowledge Angela Afa from the New York University School of Medicine, who was a diversity supplement awardee on our project, who has led a lot of this work. And so human-centered design is a very engaging process where we had patients, we had providers, nurses, doctors, social workers, getting together to try to think about how do we improve hypertension and cholesterol care for our patients. And we ended up with this 4-component intervention, which you can see here. Again, the most important of which I think are home blood pressure monitoring and a nurse-led care coordination. We're conducting a randomized controlled trial currently, looking at the effect of this intervention versus an education control over 12 months, with a primary outcome of systolic blood pressure and a secondary outcome of non-HDL cholesterol. This is what we would call a hybrid type 1 design, where we are looking at effectiveness outcomes, but also looking at implementation. One of those implementation measures is this concept that I've already talked about of provider trust and communication. How do our patients think about their trust and communication ties with their HIV docs versus their non-HIV docs? And how can we, through this intervention, improve the balance of those ties? Happy to say that we're now fully enrolled with a sample size of 300, stratified equally across all 3 sites of our trial. And interestingly, you can see that we started pre-COVID, and we have the ability now to look at the effects of COVID-19 on CVD self-management behaviors in people living with HIV. So we were awarded a COVID supplement to look at this in our trial, and so have examined interpersonal factors such as stress and loneliness, interpersonal factors, and community factors such as I've mentioned before. We have adapted the intervention through another human-centered design process to actually be a virtual-only intervention, and are looking at a virtual-only intervention in a subset of 75 patients. So don't have results yet, but please stay tuned, and we'll come back another time to give results of that trial. So in conclusion, I'll end by saying people living with HIV are at increased risk for a broad spectrum of cardiovascular diseases, including ASCVD and heart failure, and women in particular may be particularly vulnerable. Residual inflammation, despite effective antiretroviral therapy, is an important contributor to HIV-specific risk, but traditional risk factors, when you think about, again, from a population level, are more determinative of absolute risk. And so we believe it's time to extend the HIV treatment cascade for cardiovascular disease prevention by focusing on these top 3 risk factors shown here: hypertension, smoking, and cholesterol. And through close collaboration between specialists and multidisciplinary teams, I think we really do have the potential to transform the quality of prevention care for people living with HIV. And I'll end with this acknowledgement and happy to take questions.
Thank you so much, Chris. There are actually a few questions in the chat, as well as a couple in the Q&A. So I'll start by going through when they came in. Wei Tang asked about, with regards to the monoclonal antibody, is the inflammatory profile the same in people with HIV versus the general population, so that the monoclonal antibody interferes in the same way?
Yeah, so the canakinumab trial. So, that trial was in patients who had some residual elevation of CRP, but our people living with HIV have a little bit more inflammation than that population. So I think that there is potential, perhaps, that there's more benefit in people living with HIV, although frankly, it's going to be hard to ultimately do a trial that proves that. Can you comment on statin, on traditional risk factors in inflammation? So yeah, absolutely. Didn't talk about Reprieve. Many of you know, as part of Grace McComsey's Saturn HIV trial, which has shown that there is a decrease potentially in some of those inflammation markers. And so we'll see what Reprieve shows. And rosuvastatin in particular was used in our trial in Cleveland. Pitavastatin is a moderate intensity statin, so I think it will have less effect in Reprieve than what we saw in Saturn, but don't know that for sure. Do you want to decide where to go next, Teresa?
Yeah, great. Tegan asked, how do you reconcile the fact that weight loss rarely happens long-term and can lead to adverse mental health effects, such as eating disorders, with the fact that it is indicated as a preventative measure for cardiovascular disease?
Yeah, so I am not a weight loss specialist, which is why we need multidisciplinary teams. I think the mental health aspects of weight management are incredibly important, and I look forward to partnering with people at the University of Washington who are thinking about those sorts of things to see if we can get our patients into comprehensive weight management programs. I do think that bypass surgery and other sorts of surgical interventions do benefit certain patients, and have advocated for that in some patients.
Great, thank you. A couple of questions in the Q&A. Is there any risk of worsening NASH with the PCSK9 inhibitors by shunting LDL into the liver?
Good question. So to my knowledge, I don't know if that's been studied, and I'll probably go try to figure that out after this call is over. But an interesting question.
John Bowie also asked, what are your overall recommendations for when to start a statin? Thoughts for using Reynolds score that includes CRP to take into account inflammation for deciding on statin use?
Great question. So I didn't focus on that today because I just did an echo series on that a few weeks ago. We can certainly point you to the recording for that. But there are a number of different approaches to risk prediction. And in my practice, I just use the ACC-AHA risk score. There is a DAD risk score that accounts for certain antiretroviral use. But in general, it's probably not necessary to use an HIV specific score. I think that the recommendation of the 2018 guidelines was to consider HIV as a quote unquote risk enhancer in your discussions with patients about whether or not to start a statin. So I think you take the risk calculator as a baseline, this is your estimated risk. And then you have a discussion with patients, and every patient is different. They will weigh the risks and the benefits of statin therapy differently. I think we have to be good about really having a convincing discussion about the true risks of statins and trying to dispel myths. But it's always ultimately a patient discussion or patient provider discussion. Hopefully that answers your question.
Great. Matt Niederschmidt asked a good question here about, could you discuss a little bit about the risk of using one ARV over another? And I think he's specifically referring to abacavir, the various studies about abacavir and increased cardiovascular risk, and balancing that out with TAF-based regimens and dolutegravir, which could lead to weight gain.
Absolutely. These are things that I know HIV clinicians think a lot about. And unfortunately, I decided today to stay away from ART because I think that might be a whole talk on its own. And I'd love to come back at some point for an echo or clinical conference to discuss specifically ART. I think it does deserve kind of its own discussion. Just to briefly mention, I do believe that abacavir is associated with an increased risk. I also am very intrigued by analysis from DAD that would suggest that once you have a cardiovascular event and get put on aspirin, if you look at those who continue abacavir regimens versus those who don't, there really is no increased risk of abacavir in those who are continuing to use aspirin. So the question is, does aspirin somehow counterbalance the platelet effects of abacavir that have been shown in some small studies to potentially be the mechanism of risk? So I'll stop there. Again, I think it deserves its own kind of talk, as well as the issues with integrase inhibitors and weight gain, and TAF as well. So look forward to maybe discussing that more at another time.
Thank you. I think there's one more question from Wei Tang about does GLP-1 agonist provide additional benefit in HIV specifically versus traditional risk factors?
Versus people without HIV? Yeah. So there is a GLP-1 agonist trial that is wrapping up, again, conducted in Cleveland by Grace McCumsey, looking at semaglutide in particular versus placebo in people living with HIV who have obesity. So trying to quantify the amount of weight loss associated with semaglutide, but also looking at inflammation and other sorts of things. So I like GLP-1 agonists. I think they're great for people, particularly who are overweight, who are looking for weight loss and diabetes control. Hopefully that answers your question. I don't know. There's not a study that would suggest that it's any better in people living with HIV, but we'll see what Grace's study shows.
Great. Thank you so much, Chris, for that great talk this morning. And thank you all for participating.
Well, thanks for inviting me, Teresa. It was fun.
Great. We look forward to working with you more in Madison Clinic. So thank you.
Have a great day.